All
So,
right.
good morning, everyone. Thank you for participating in what we consider our kickoff for the rural health value effort that we're doing. I'm Brad Gibbons. I'm the acting director of the Center for Rural Health. Other people will introduce themselves as we go, but I want to introduce my good colleague, Nicole Threadgold. Many of you know Nicole and have worked with her either through our Flex program or part of our SHIP program. So you're familiar with Nicole, and I greatly value her involvement with this. Um, and what is this? um, uh, this is something that's coming out of the funds from the CDC. And the CDC provided dollars to the states. North Dakota was able to get a large amount of funding. The state health department reached out to the Center for Rural Health and essentially said, do you have any ideas? And we said, yeah, we have some ideas. So some of the things that we've had funded include elements related to health workforce, some of the things that Stacy Kuzler is doing with the rural hospitals that includes covering a little bit of additional costs for when you have medical or health science students come out to cover the costs of those students, and then other things that are related to workforce, including putting a pretty good boost into our HOSA program that runs through our AHEC. So there are things like that. Kylie Nielsen in our office was working with the physical plant upgrades. This was dollars that we were able to provide to critical access hospitals to use for assessment and analysis for them to do physical plant changes. We learned a lot about the physical plants of our hospitals during the pandemic, and that we weren't always prepared in our physical plants. So this was an opportunity to do that. Colette Adamson is doing some work with our tribal nations in North Dakota, and there are some things revolving around resiliency. So those are some of the things that we did in the CDC, along with this thing called value. Uh, I have had a strong interest in our national movement from volume to value, going back to, I suppose, about 2010, when I really became much more cognizant of it through the Affordable Care Act. And I've always been intrigued by it. I see a lot of benefit that can happen, and it's coming and it's here. The issue that I've always had grave concerns about is, are we ready in North Dakota? I see some activities in other states, and I see them moving forward, taking big steps, big strides. And the sense has been in North Dakota, maybe we're not quite ready. And again, it's nobody's fault. As I said a little bit ago, our rural hospitals don't have the luxury of time. So you can't just drop everything and become an expert. We have about 8 critical access hospitals that are part of an accountable care organization. Many of you are working with Blue Cross Blue Shield and their Blue Alliance. So we have pockets of experience happening. But I felt I wanted to basically develop a blueprint where we could have a set process where we could work with critical access hospitals in North Dakota to essentially help prep them, help prepare them, give them a greater sense of understanding of what value means, how it relates to quality, how all of the stuff that you're doing that's related to HIT and quality, and there's these weird concepts called population health and social determinants of health, and how all of that comes together within a restructured health system that also creates a different avenue of payment for providers. Are we prepared? I could be wrong, but my assessment was not as prepared as we could be. So we used the CDC funds to basically develop a blueprint. And in that blueprint, we now have colleagues who are working with us. And I'm going to be turning it over to them in a minute. But the Rural Health Value Group, which I think of as the University of Iowa, and also Strata Health in Minneapolis, and Strata Health is quality oriented. That's their primary focus. And I've had the good fortune in my career of having learned a lot from people like Dr. Clint McKinney and also Carla Wang. I've attended numerous sessions that they've done. What little bit I do understand, and I'll give credit to them and other people. And what I don't understand, let's just say I just didn't learn it. It's not their fault that I didn't learn everything. But and then also their partner with New Point Healthcare Advisors that are part of this, and Nate White is part of that. What in before I hand this off, I basically want to let you know you're not mandated to do this. You are coming to this because you are curious, that you see there may be a potential. I want to learn more about this. I want to know what the impact is in my hospital. What is the impact on our patients, our neighbors, our friends? And that's your motivation in doing this. We don't get an opportunity to do that all the time. A lot of times we're basically trying to catch up, or we're reacting to something that's already been dictated to us. This is an opportunity for critical access hospitals in North Dakota to basically control a little bit of their environment and determine the direction that you want to go. And how do we understand this, and how do we make it work for us? So there's no requirement that you do this. I often remember the words of Matt Shahan. Matt was part of our original advisory group. Matt was the CEO in Hettinger, so some of you know Matt. But Matt was very clear, we want something so we get ahead of this. There was a concern on the part of some of our providers that somebody somewhere down the line is going to make us do something. And we typically don't like that. So is there a way that North Dakota can actually get ahead of the curve, is the way he framed it. And I think that's essentially what we're trying to do. My final comment is, this is not just some strange idea that came from Brad Gibbons. Although some of the initial strange ideas did come from Brad Gibbons. But we put together an advisory group of 6 or 7 critical access hospital CEOs. And I vetted everything that I was thinking about through them. And what we came up with was something that they essentially endorsed. I did not think that I could come up with something that was not recognized by cause as something that would work in their environment. So it was critically important. And this is very much a part of how the Center for Rural Health operates. You're the experts. You do this day to day. You live in this world. If we're going to do something to help you, we want your input on designing something. So the model we came up with was basically put together with the group of critical access hospitals in North Dakota. Now I think I have probably dug myself a deep enough hole, and hopefully said what I really needed to say. So I'm going to really turn it over to Clint and Carla and Nate and others to really tell you what this is about. So they'll walk you through it. So I'm just so thrilled and honored to be working with this group of people. These are experts, and not only in understanding value and quality, but they work in rural. They've had experience working in other states. They've worked with the global budget idea in Pennsylvania. They work closely with CMS in terms of trying to think our way through that chart model and other things. So they not only understand the concept, they also understand rural. And I'm not trying to take this away from Carla when she introduces herself, but I'm very proud of the fact that Carla has deep roots in North Dakota. So she's basically a NODAC. So that's a compliment from me, Carla, when I call you a NODAC. So I'll turn it over to Clint and Carla.
All righty. Well, thank you, Brad, and thank you, Nicole, and good morning to all of you on the call. We're excited to talk about this new project. I'm here with my colleagues Kelly O'Neill and Nate White and Carla. So I'm speaking for them a little bit today, but we have quite a team that we've put together to help run this project. We're very appreciative to Brad and Nicole for making this opportunity for us, and frankly, we think for you as well too. So I'd like to talk about that opportunity for the next 15 or 20 minutes, and then answer any questions that you might have. So let me start here with some slides. And there we go. And I'm going to move this a little bit for me there. So it's kind of a wordy title here, but the Rural Health Value North Dakota Value-Based Care and Payment Project, and we'll shorten it a little bit. But the critical access hospitals and their service lines in North Dakota are a critical part of this project. not just the targets, but fundamental to the project. And that's why we're asking for your applications to become a part of this project. So let me talk a little bit about that, if I could. But before I do that, I want to reiterate what Brad said. What's the purpose of this? And it is to help critical access hospitals in North Dakota and their service lines, their clinics, or their nursing homes, or their home health agencies, or their ambulance services, start to think about and prepare for value-based care so they can receive value-based payment. That's what we're kind of talking about here. We don't want to be put in a position where a payer slaps a contract on our desk and says, either you take this contract, which is value-based, or you're not in our network. And you are kind of like a deer in the headlights saying, I don't know how to do value-based care to be successful in a value-based payment contract. So we want to preempt that with some of this work. So let me go ahead and get started. Well, first of all, to reiterate what Brad said, this is a federally funded project, but sponsored by the University of North Dakota's Center for Rural Health. We're here, as the bullet says, to assist critical access hospitals and their service lines and their providers prepare for value-based care and payment. The technical assistance that's going to be provided will be through a joint team, both Rural Health Value and New Point Healthcare advisors. I'll introduce those teams in just a second, but it's critical that you understand this is no cost to the participants in North Dakota. This is being funded through Brad and Nicole from the Centers for Disease in Atlanta. So here's kind of a project overview. And what we've done is we've really divided this project into 3 different buckets. The first is an environmental scan, and we're already starting to work on that, where we're looking at publicly available databases to get a sense of both health, like population health, and healthcare services in North Dakota. We'd like to examine, as we are able, value-based care contracts that are already in place. We understand that Blue Cross Blue Shield will be the administrator for the Medicaid expansion in North Dakota, and they have said that they will be introducing value-based contracts within that. I think I understand also that the Department of Health and Human Services, now combined in North Dakota, is considering value-based contracts for its Medicaid work. And certainly there are opportunities in Medicare for value-based contracting, and 8 of your colleagues or you yourselves are already participating in Medicare shared savings through Caravan. We like to have some national comparisons. It's our belief that North Dakota hospitals really aren't that different than hospitals elsewhere in the country. You have the same issues. Your issues are, how do we improve the quality of care that we deliver? How do we do it in an efficient way? And how do we provide satisfied patients, families, and the care we provide? And then we like to, from that environmental scan, make some lessons learned and recommendations based on that. The next bucket of this is direct technical assistance. I wanted to say on the ground. It's really more virtual, but you get what I'm talking about. And we'll be working with what we call core critical access hospitals, just a limited small number, just because the scope of this project isn't enough to work with all 36 or 37. So we'll be working directly with just a small subset. We'll be doing 3 main projects with these selected hospitals. We'll be doing a value-based care capacity assessment survey and then develop action plans based on the opportunities identified in that survey. We're going to be developing a community engagement plan. You know, value-based care, it takes a village to do value-based care. This is not something a hospital can go alone with, and we need to understand how can we best marshal the other resources in our communities to improve the health of our communities. Lastly, and very importantly, is finance. I try to remind folks that I talk to who are not in hospital administration or clinic administration, and I try to remind policymakers in Washington and state capitals that unless you design a program that is at least has a good chance of being financially successful, at least not losing money for the organization you're targeting, it's going to be a non-starter. We need to understand what the financial implications of value-based care, value-based payment contracts look like. And our project will start to develop financial scenarios, or pro formas is maybe even a better word, that look at first the current state of affairs. If we continue on as we are with cost-based reimbursement in our critical access hospitals, physician fee schedules in our private clinics, if we continue as we are, if we look at how costs are trending, if we look how revenue is trending, where will we be in 5 years? What does that look like? And then let's compare that to if we were participating in an ACO, if we were given a global budget for our hospital, if we were participating in one of the 3 Blue Alliance programs, what would it look like 5 years from now for our hospital? Because that's of critical importance. And then, as Brad alluded to, and I appreciate the compliment, our team has really been in this space for quite a while. The Rural Health Value Team has been funded by the Federal Office of Rural Health Policy for the past decade to really work with the leaders in value-based care and payment across the country, rural leaders. And we hope that rural North Dakota critical access hospitals become a member of that leadership group. Lastly, we will be focusing on statewide education. Pretty early in the project, we'll develop a webinar that just helps those who are less familiar with value-based care and value-based payment understand the fundamentals of this and what it might mean to rural hospitals and clinics in the future. Also, we'll take some of that technical assistance and the lessons we learned in that technical assistance to tell the rest of the state about value-based care capacity assessments, community engagement plans, financial modeling, and performance. We want this group of core hospitals to be the educators for the rest of the state. Here, let me introduce the team. It is twofold, and I'm going to ask Carla to introduce the Rural Health Value Team, please.
Thanks, Clint. So as Clint mentioned, Rural Health Value has been a partnership between the Rupri Center at the University of Iowa and Stratus Health for about a decade. Our Rupri team members are Clint, who you've met, Dr. Keith Mueller, who is really expert in lots of things, but really deeply involved in policy. So that's part of the lens that he will be bringing to the table for us. And Kristen Wilson, who is also faculty there and has experience in community engagement. So she's a newer member to our team. We're excited to bring her on board. And then finally, Fred Ulrich is also with the University of Iowa side of Rural Health Value. He calls himself, and we have taken that moniker as well, a data wrangler. So he's the one that tries to put together and make sense of all these pieces and parts of data. From the Stratus Health side, we have Jennifer Lundblad, who is our CEO, but also has deep experience and expertise. She's part of the Rupri Health Policy Panel. She actually did her PhD work on patient safety culture in rural hospitals, so lots of deep expertise there. Kelly O'Neill is our fantastic lead project manager or program manager on this, and is going to be helping us kind of herd all the cats and keep things going and moving together in the timeline. And then I'm the last member on our team. As Brad mentioned, I love working in rural health. I do a lot of it nationally, but in North Dakota, it is very personal to me. I graduated from high school in Watford City. My mom is from Starkweather. My dad is from Cooperstown. My husband's from Center. I have friends and family sprinkled all over North Dakota. So what you do really makes a difference in the lives of your community, but it also makes a difference in the lives of people who I know and who are close to me. So thank you for your willingness to kind of engage and be excited about this work. And then I'll turn to Nate.
Thank you. Nice to meet, I'm not sure who was on the phone, but very nice to meet you. I'm Nate White, president of New Point Healthcare Advisors. We are a boutique healthcare consulting firm. I lead primarily the affiliations and strategic networks practice. I've worked with many of the CEOs within the state of North Dakota. I actually lived there running the Sanford Fargo Hospital for a few years, in fact. So very familiar with the area. We've got a great team. Of course, I'm biased. There's a few of them listed here that are working on this project. Peggy as a clinical background, but also a great deal of finance expertise. Brett Norrell, former CEO and CFO of critical access hospitals, primarily in the state of Wisconsin. And then Joe Lupka, our chairman, who has been involved nationwide in rural healthcare for I won't say how many decades, but more than a couple. So thank you for allowing us to be part of this project. We're excited.
Great. Thank you, Nate. Thank you, Carla, very much. So I mentioned before about core critical access hospitals. So what we want to do, and that's actually the purpose of this call and presentation, is to select a small group of North Dakota critical access hospitals to be selected right out this month to participate in activities that will extend from October of this year through May of 2023. So it's a relatively time-limited project. It's not going to be forever. The participating hospitals, or what we're calling core hospitals, will receive both coaching and support to, again, prepare for value-based care and payment. In return, you'll provide input and information for us to make recommendations at a state level for policy considerations and other strategy discussions. I won't read all this, but you'll have for your reference a kind of a broad timeline. We are going to actually identify our core hospitals here shortly, and each one of these hospitals will receive a very detailed data profile of the health and healthcare in their community. We'll also start this fall, or at least late this fall, requesting information from you to help us complete this. In the winter, we'll be doing that value-based care capacity assessment I was describing, and then develop an action plan around opportunities identified in that survey. We'll work on our community engagement plan, and then Nate and his team will be working on those financial pro formas that I discussed earlier. And then towards the end of that time, we'll start focusing a little bit more on how we can develop a roadmap for what can happen after this project ends. We'll try to develop some consensus building opportunities to get state and other leadership input into the process. And then towards the end of April, we'll have a wrap-up presentation and then a final report on towards the end of May or shortly into June. Let me then describe for you, and again, it's a little bit of a wordy slide, so I won't read it verbatim, but we feel that there's quite a few benefits that will be available to these core critical access hospitals. Again, this is professional consulting. We've done this type of work all across the country, and it's something that really excites us. Nate and I were just talking about this yesterday, that when we get excited about a project, it just makes the whole project so much more fun, and we're all really excited about where this can go. So you'll receive this health and healthcare data profile for your specific community and your healthcare system. We will do this value-based care strategic assessment and action plan, community engagement plan, and then the financial scenarios. We'll assign 2 coaches to each core critical access hospital, one from NewPoint and one from Rural Health Value. And this will provide you an opportunity also to network with other critical access hospital leaders and teams in the state. You'll have access to multiple resources around value-based care and payment. And I think it's a benefit, an opportunity to inform state-based policy and to lead North Dakota health transformation. So I think those are all very important benefits of participating in the program. Now, with benefits comes some expectations. We do need data and information from you, but all of us are quite used to working with sensitive data. NewPoint works with financial data for hospitals that's proprietary. They understand how to manage those data so they remain secure and private. Carla works with quality data for years and across the country. She knows how to maintain confidentiality and privacy of quality data. So we will work very diligently to make sure that your data are protected. But we will need data from these core hospitals around things like market, financial reports, quality reports, and community health needs assessment. We believe that this will probably require, on average, it will vary, 3 to 5 hours per month of your hospital staff's time. And that's for education and coaching sessions. We'll need your help in completing the value-based care assessment, but then together we'll develop an action plan around those capacities and similarly around community engagement plans. And then we'll ask you to review the pro formas that NewPoint will be preparing. we'll ask you to identify a primary contact, often that's the CEO of the hospital, and a secondary contact who's responsible for communication and support during the project. And we really do need this. We need an individual who's in the know in the CAH, but also who can be responsive to an email or a voicemail within, say, 2 business days. So we need that person. We need you to be active in the project through May. That's as long as the project lasts. And then we ask that we publicly recognize your good work as part of this, because we want the other critical access hospitals in the state to benefit from your participation. And that's the sharing of experiences and lessons learned with key partners and other CAHs. Here's how it works. Ridiculously easy. You received an email from Nicole, I believe day before yesterday. And it's quick and easy. And it has a Qualtrics, it's an online survey link in that email. And here it is. This is all there is. You need to provide the name of your critical access hospital, the CEO's contact information, which is simply name and email, and maybe phone number. And then briefly, and when I say briefly, I got it underlined. I'm talking about 1 to 2 or 3 sentences only. Describe why you wish to join the Rural Health Value North Dakota Project. And then we're going to select 4 to 6 North Dakota critical access hospitals for focused technical assistance, as I was describing. If you have any questions, you can contact any of us, but our portal for questions is our fabulous project manager, Kelly O'Neill, and her email address is there, but certainly you can get hold of Nicole or Brad if you have any questions. And here's kind of the ultimate goal. Our ultimate goal of this project, like all the projects I think that Carla and Kelly and New Point work on, is we want healthy critical access hospitals in rural communities. We want places where our kids have a good education and good experience growing up, where our workers are productive and our elderly are safe and secure as they age. The disclaimer for funding is always has to be there, so that you'll see that at the bottom. But I'll stop, and all of us can answer your questions if you have any. Thank you.
All right, thanks Clint and Carla and Nate, everyone for the presentation, and Brad for your kickoff. We'd like to open it up for questions at this time. And then just a quick reminder, if we have those who have joined in the meantime and have not typed your name and facility into the chat, please do so to record attendance. And then I see one phone call, a 701-628 phone number. So if you could just reach out to me individually, or if you're okay just hollering your name out and unmuting yourself, please do so we can record your attendance. And then we'll just open it up for questions. Either feel free to unmute yourself and ask, or type into the chat and I can be watching the chat.
The 628 number is Janelle Borrud. I'm the clinic manager at Montrose County Medical Clinic.
All right, thank you so much, Janelle.
Hi, this is Paula Wilkie from SMP Health St. Kateri calling. We're already in the Caravan ACO. Yeah. And great, they're great to work with. Now with the Medicaid expansion coming on board, and our facility for any CAW hospital has the highest Medicaid expansion attributed to it. So being part of Caravan, does that automatically kick us out of this? Because we could use all the help with the Medicaid expansion that we can. It's a very hard population to manage, and just ideas on, for them to receive better care for any of those patients that are attributed to that population or insurance.
No, I can speak to your question. First, the really easy, quick answer is no. You are not precluded from participating in this program simply because you're working with Caravan. In fact, as Carla and I have worked in Rural Health Value over the years, we've been asked by our funder, the Federal Office of Rural Health Policy, to primarily work with the trendsetters, the people who get it, who understand that these changes are coming and want to learn how to be successful in those changes. However, in this particular project, we understand that various critical access hospitals in North Dakota have varying levels of experience with value-based care. That's okay. we're here to learn from one another as well. And in fact, as the team knows, my primary goal for participation as a core hospital is to notice and take advantage of enthusiastic curiosity. So we want somebody who really wants to learn, who wants to share, and wants to grow. That's who we want to participate.
Thank you. That answered my question.
Thank you.
Other questions any of the attendees might have? Not seeing anything in the chat at the moment.
Again, I think the hope that I had in trying to put this together is, as Clint said, hospitals are at varying degrees of experience with value. And we have, again, some that have been part of a Caravan ACO 8, and we know many of you are probably in the first level of working with Blue Alliance, but ideally it's beneficial to have some cause that maybe they've got a little bit of experience under their belt, but this is a really great opportunity for also a hospital. Well, you know, I really don't know about this. I don't know what this is going to do going forward. And this might be a fairly safe way for me to get some understanding. Honestly, I don't think we could have designed a safer off ramp for people, or on ramp really for people. You're not going to get hurt doing this, and you have the opportunity to learn a lot about your situation and what it can be. So I think that's our hope. So there hopefully will be a few cause. They maybe are better than ACO. They understand concepts like care coordination, and then others are, that's all murky yet to me. So what does that mean?
Okay. I'm just going to go ahead and include in chat here Kelly's email for any questions that might come up after our call ends here today. And then also always feel free to reach out to Brad or myself or Kylie as well, and we can help connect with our team regarding the project. But in the interest of time, I'll just ask one more time if there's any questions. Feel free to speak up now, or we can go ahead and take questions offline as well if they come up afterwards.
And being a NODAC, I understand a little bit of our culture, which is you may not ask, you may have a question, but you may not ask publicly. So you may be calling or emailing Nicole and I to go, okay, what's the straight scoop on this, Brad? Come on. So anyway, we're available. Just call us or email us, and we'll help you as best we can.
Excellent.
Absolutely.
Well, thank you all very much. Appreciate it. Thank you, Brad. Thanks, Nicole.
Yeah.
Yes. Thanks everyone
Thank
for
you.
attending.
Bye.
Yep.
Have a great day.
Take care. Great. Thank you.
Thank you.